Hello and welcome to HPS Pharmacies webcast lecture. My name is Sallie Drake and I'm the Clinical Communications Coordinator at HPS. This educational presentation can be used to contribute to your CPD hours to meet the standards set for professional registration purposes. So today I'll be discussing medication management and dysphagia. So what exactly is dysphagia? Dysphagia is used to describe swallowing difficulties. It can encompass problems with sucking, swallowing, drinking, chewing, and controlling saliva. It can also significantly affect a person's ability to take medications by mouth. And it is estimated that around 1 million Australians suffer from dysphagia, with the condition typically more common in older individuals. So dysphagia can be caused by quite a range of issues, including stroke and other neurological conditions, certain cancers and treatment for those cancers, but also by a range of medications. So some medications can either cause or exacerbate dysphagia due to adverse effects such as dry mouth, induction of movement disorders, depression of the central nervous system, direct mucosal damage. So if medications are thought to be contributing to swallowing difficulties, a full medication review is recommended. So this might identify medications that are no longer necessary or safer alternatives to existing therapies. So dry mouth, also known as xerostomia, is quite a common cause of dysphagia. It can impair swallowing and is often associated with anticholinergic medications. And it's important to recognise that anticholinergic properties are not just limited to drugs that are classified as anticholinergics. So a number of medications have varying degrees of anticholinergic effects, and that would include things like antihistamines, some antipsychotics, and many antidepressants. And these effects are additive, so patients taking multiple medications are much more likely to suffer from this condition. So some of the therapies that can be used to treat xerostomia include saliva substitutes. So they're often supplied as an oral spray or a mouthwash, or products that stimulate saliva production. So that includes chewing gum and throat lozenges, preferably sugar-free varieties. The usefulness of these therapies is often limited by their quite short duration of action though. So to be effective, patients would need to be administering these products multiple times a day. So other more general considerations include ensuring adequate hydration, avoiding smoking, avoiding oral preparations that contain alcohol. So this includes quite a number of over-the-counter mouthwashes, and also ensuring that good oral hygiene is maintained because these patients are at greater risk of dental cavities. So this table shows the range of medications that are associated with swallowing difficulties. It's certainly not an exhaustive list. There's quite a number more medications, but it just shows that there's quite a range of medications from drugs used to treat blood pressure problems, chemotherapeutics, all the way through to supplements that might be purchased over the counter. So if a patient does present with swallowing difficulties, it might be really tempting just to open the capsule or simply crush the tablet. However, that should be considered a last resort, as there are a number of risks associated with altering a medication. So this could include the patient not receiving the full dose. This might be due to remnants of the tablet left on the tablet crusher or the medication cup used to administer the dose. And this would be particularly relevant for medicines with a narrow therapeutic index. So we'd be thinking about drugs like digoxin and warfarin. It might be a risk associated there. Crushing the tablet may have an effect on the stability. This may be less likely if you were to prepare the dose immediately before administration. There may be an effect on absorption, so the effectiveness of the tablet may be reduced, or at the other extreme, toxicity could be increased. The drug might have a direct irritant effect, so examples of that would be alendronate and potassium chloride. So altering those dose forms could present a risk of gastroesophageal irritation or ulceration. There could be palatability issues. So many medicines are coated to disguise unpleasant taste. And if you were to crush those tablets, the palatability would reduce, which could affect patient compliance. And there's also a risk to the person preparing the medicines due to liberation of powders that could be either inhaled or come into contact with the skin or the eyes or mucous membranes. So it's quite important to consider appropriate precautions, which might include gloves or goggles. So when we think about risks to the healthcare provider here, we typically consider cytotoxic medications, which would include many medicines used to treat cancer, but also some immunosuppressants and some drugs used to treat conditions such as psoriasis and rheumatoid arthritis. So, for example, methotrexate. In addition to cytotoxic medications, there's also quite a range of medications that are classified as hazardous or potentially hazardous. So this would include hormone preparations, such as hormone replacement therapy and oral contraceptives, immunosuppressants, and some antivirals, such as valganciclovir. And additional consideration should be made for women who are pregnant or considering becoming pregnant to avoid teratogenic medications. So that's anything that's in the category D or category X. And lastly, there are potential legal implications if you're administering medicines in a manner that deviates from what's recommended in the product information. The ways that you could minimise your legal liability here would obviously be to consult with the prescriber in the first instance, and to ensure that you're consulting appropriate references so that your method of administration is safe and effective, and to get the patient's written consent if that's at all possible. Okay, so we've mentioned that altering a medication would be a last resort. So what would be something that you could consider as a first line step for a patient that's having trouble swallowing their tablets? So first up, you could consider a medication lubricant such as glue. So this is just a very thick gel that just helps to make the swallowing process a little bit easier. This might be appropriate for someone with a milder form of dysphagia. So these products have no known drug interactions and either known or very minimal effects on drug release rates. Other options that could be considered by the prescriber include different formulations of the same medicine. For example, the prescriber may wish to switch to an oral liquid or a dispersible form. This might not be appropriate for patients with more severe forms of dysphagia, but for some patients it may be appropriate. In this case, it would be worthwhile considering some of the differences in excipients in these different formulations. So for example, dispersible tablets often have quite a high amount of sodium in them, which could be important for patients with high blood pressure. And some oral liquids do contain alcohol, so they might not be appropriate for children or patients with a history of alcohol use disorder. Another option could be alternative routes of administration. So many oral tablets are also available in, say, a buccal form or a transdermal form, and parenteral administration could also be considered. And lastly, an alternative medicine from the same class could be considered. So for example, oxycodone modified release tablets should never be crushed. However, there is transdermal options of different opioids available, such as fentanyl patches, which the prescriber might want to consider. So switching dose forms can result in changes in bioavailability though, and also the side effect profile. And changes to the dosing regimen may be required as well, which could cause issues for patients in terms of compliance if the dosing regimen becomes more complicated. And another point to consider is the potential cost associated with changing formulations. So in general, oral liquids are more expensive per dose than tablets and capsules. In addition, some alternative formulations may not be subsidised on the pharmaceutical benefit scheme. So for example, esomeprazole tablets are subsidised, however, the granules for oral suspension are not. And so that may have significant implications for the patient if they're going to have those medications in an ongoing manner. So if a suitable alternative is not available, you may need to alter that dose form. So information on how best to do this can often be found in the product information. If there's nothing there, you might want to consult the Don't Rush to Crush handbook. This is a really good guide with some great practical tips that's published by the Society of Hospital Pharmacists of Australia. And you can always consult with your pharmacist, of course. Some general points to note if you are altering a medication is that syringes for injection must never be used for oral medications. Medicines must always be given once at a time, and they should never be mixed with enteral fees. So this is just to avoid issues with compatibility. And the equipment used to crush medicines must be thoroughly cleaned. So this is really important to prevent cross-contamination so that the next patient doesn't have issues with remnants. Okay, so there's quite a range of different tablet coatings that you may notice. So some are film and sugar coated. These are quite simple coatings on medicines. They don't impact the release rate to any great extent. Therefore, crushing them generally isn't going to have a significant impact on the absorption rate. So crushing these types of tablets may be okay. However, it's important to consider the reason why the tablet was coated in the first place. So it may have been to disguise an unpleasant taste, or it may be to prevent irritation. So medications such as doxycycline are often film coated because the doxycycline is quite irritating to the gastric mucosa. And secondly, we have enteric coated medicines. So these coatings are designed to pass intact through the stomach, through the through the acidic environment of the stomach, and then dissolve later in the more basic conditions of the intestines. So medicines that are enteric coated must never be crushed, otherwise the release characteristics will be significantly affected. The reasons for enteric coatings include preventing degradation of the active ingredient, protecting the gastrointestinal system, or for delivering the active ingredient to a specific site further along in the stomach. Products that are enteric coated can often be identified by the use of EC or EN in the brand name. And lastly, we have modified release medicines. So these are medicines that are coated or engineered in some other way to modify their release. So this is typically to slow down the release of the drug, which allows for more consistent blood levels and generally less frequent dosing. So these medications also must never be crushed. Crushing can lead to a phenomenon known as dose dumping, whereby either the full dose or a significantly larger proportion of the dose is released at the one time. So this can result in significant adverse effects and toxicity. For example, many opioids are formulated in a modified release preparation, and crushing those can lead to potentially toxic, potentially fatal outcomes. There's quite a range of abbreviations used to identify modified release products. So that includes MR, SR, CD, but you may also see things like mono and duo. If you are unsure, you can always consult with the product information to make sure what kind of coding is on your tablets. So to summarise, when a patient presents with swallowing difficulties, it's an excellent time to conduct a medication review. So this may identify medicines that are contributing to the swallowing issues and also changes that could be made to improve the condition for the patient. If essential medicines cannot be swallowed, it may be safer to swap through a proprietary product from a different route or a different formulation. If this is not appropriate, alterations can be done, but they should be done in consultation with the prescriber and after consulting appropriate references. So thank you everyone for your time today. I hope that you enjoyed this presentation and found it useful to your practice. If you would like a copy of the notes or if you have any questions at all, please email myself at sallie.drake@hps.com.au.